Okay, I want to welcome you all to Trio Maryland, the Virtual Transplant Journey 2024. We look forward to a program filled with great information and takeaways for everyone participating. My name is Rachel McFadden. I'm here helping to moderate today's panel or today's discussion. And to open the event, we are going to welcome Marty Marin, the president and co-founder of Trio Maryland.
Good morning and welcome to Trio Maryland's third virtual transplant conference. We are so excited that you are joining us today for this educational event. I am Marty Marin, president and co-founder of the Maryland chapter of Trio, which stands for Transplant Recipients International Organization. I am a liver recipient November 2009 at Johns Hopkins Hospital, and I'm closing in on 15 years or 5,296 days. Yay. After my transplant, I became a volunteer at Johns Hopkins Hospital and at Infinite Legacy, and then started working on establishing a Maryland chapter of Trio. Our mission is to connect transplant recipients with one another, to provide education on transplant topics, and by offering non-clinical support, we complement the services of our healthcare professionals. During the last 11 years, we have offered over 120 monthly educational meetings. We have hosted 5 in-person conferences and 3 virtual conferences. Transplantation is a journey, and our conference brings you topics and information to help you navigate the next stage of your life. Trio Maryland is a nonprofit 501c3 organization founded and managed by transplant recipients. We are self-funded, raising money we need to continue our programs. We can offer great events due to the generosity of our members and families. With your financial support, Trio Maryland will continue to furnish timely and educational information to the transplant community.
What a great introduction and a great way to kick off the 2024 event. We couldn't do it without our sponsors, and we encourage all of you to visit their websites to learn more. Trio is excited to be bringing this conference to you virtually. And a quick reminder about your individual schedule. Your sessions will have individual Zoom links, so you can access those links 15 minutes before the session starts, and then the webinar will officially open 5 minutes before the start time, just like this one did today. If you need any support today during the webinars, please text 443-280-2217. I will drop that in the chat for anybody who wants to grab it. The first session today is Liver Transplant 101. Please post your questions for today's session in the Q&A tab, and we will share that with the speaker after the presentation as time allows. Our speaker is Kate Egan, and she is currently the nurse manager liver transplant at University of Maryland Medical Center. Kate started her career in transplant after graduating with her bachelor's in nursing and has worked at both Johns Hopkins and the University of Maryland Medical Center. So please welcome Kate.
Thank you. I'm really excited to be here today. I'm going to share my screen so I can share my slides. Can you see it okay? So my name is Kate Egan. I am the nurse manager of liver transplant at the University of Maryland, but I've had the pleasure of working at Johns Hopkins too, where I started as a bedside nurse. I was a patient educator at University of Maryland, and then I went back to be a liver transplant coordinator at Johns Hopkins, and then I came back to University of Maryland in 2017 and became the nurse manager in 2020. So I have been around transplant for a little while. My entire nursing career has been in transplant, and I'm excited to talk about my favorite topic, which is liver transplant. I love liver transplantation. I think it's amazing, and I get to witness incredible things every day. So I'm excited to talk about it with you guys. I hope you find this helpful. If there's something that I didn't touch on that you'd like more information on, please feel free to ask at the end. And also I will share my contact information. So if you have any questions that you didn't get an opportunity to ask today, please feel free to email me. As a disclaimer, this is based on my experience at University of Maryland and Johns Hopkins. If you have specific questions about your case or your specific care, I encourage you to reach out to your transplant team and your transplant coordinators. But if you have general questions, I'm happy to answer them today. So to start, what are the functions of the liver? The liver is super important to our body. It is involved in most bodily functions. It produces bile, which helps excrete waste and aids in the digestion of fats. It stores glycogen, which is derived from glucose in our body. And when our blood sugar gets low, glycogen is converted back to glucose, and it is like an emergent energy source. So that's super important for our body so that we don't break down muscle. Protein synthesis is part of what the liver does, and because it stores amino acids, it helps build protein in your body and aids in muscle building. It converts ammonia to urea, which is super important. And when we talk about liver dysfunction, this is something you will notice that your liver is not able to do anymore. It filters the blood of toxins. It regulates blood clotting. This is also really crucial to bodily functions. People with liver dysfunction are at a higher risk to bleed or have bleeding events. It stores iron in our body, and more than 500 essential functions of the liver have been identified. This is so important because when you have liver dysfunction, almost every bodily function and most organ systems are affected by your liver dysfunction. So what happens when your liver stops working, and what are some symptoms of liver disease? So yellowing of the eyes and skin is a really common symptom. We call this jaundice, and it's because bile has accumulated. Your body's not excreting it anymore. So it accumulates and it causes the sclera of your eyes and your skin to turn yellow. Some people also experience really severe itching because bile contains salts that deposit into your skin. And that's really uncomfortable for a lot of patients. Confusion related to the accumulation of ammonia is called hepatic encephalopathy. And this is a really life-limiting symptom that patients have who have liver disease. Because the ammonia isn't being converted to urea and is not being excreted anymore through your body, it accumulates and it causes confusion. The way that we treat that is by a medication called lactulose, but that's also very life-limiting and can really affect the quality of life for a lot of patients. It causes an accumulation of fluid in the abdomen known as ascites. So because it's not filtering the blood and toxins anymore, there's an increased buildup of pressure, and that causes ascites, which is fluid in your stomach. The way we treat that is by what's called paracentesis, which is when a catheter is inserted into the stomach and the fluid is drained, but that's a short-term solution, and some people need to get that drained up to every week, and they can drain like up to 10 liters. So that's really it really affects people's quality of life, and it's very uncomfortable for people to be carrying around all that extra fluid. And then esophageal varices is another condition caused by liver disease, and that's when I talked about the pressure builds up. Well, it kind of backtracks up through your esophagus and causes a ballooning out of the veins in your esophagus. And so they can actually rupture and bleed, and that can be a life-threatening complication from liver disease. So liver disease can be very severe, and the symptoms of it can be really life-limiting and affect the quality of life for a lot of patients. So we call liver disease when it's in its end stage cirrhosis, and it means that your liver is completely scarred. And people who are experiencing cirrhosis or have been diagnosed with cirrhosis and experiencing these decompensations oftentimes require a liver transplant evaluation. So what are some of the causes of cirrhosis? Cirrhosis is the cause of your liver disease, but there's typically or it is your liver disease, but there's typically a condition that caused it prior to that. So I think the most common one that people think of when they think of cirrhosis is alcohol cirrhosis. And that while that is one of the more common ones we see, there are a lot of other ones we also see. Hep C cirrhosis, Hep B cirrhosis, non-alcoholic fatty liver disease, or it could also be called NASH. We've changed the verbiage a little bit within the last year, but that's probably that's the second most common cause of liver disease that we are currently seeing is NASH. Cryptogenic cirrhosis, sometimes people will come in and all causes of cirrhosis have been kind of excluded, and we're not sure what has caused the cirrhosis that a patient is experiencing. PSC, it stands for primary sclerosing cholangitis, and PBC stands for primary biliary cirrhosis. And those are two conditions that can cause cirrhosis. Sometimes people have a combination of a few of these. So people might have Hep C and then they drank alcohol, and they could have a combination of both of these conditions. And that's more common than not, actually. So for patients that have cirrhosis and require a liver transplant evaluation, what's involved in that? And it can vary from center to center, but for the most part, there are things that regulatory wise, each center has to do during a transplant evaluation. So you're required to meet the transplant team. So typically in our center, how it works, the first person that you would meet is the nurse coordinator. And ideally it would be the nurse coordinator that's going to follow you throughout your transplant journey until you're transplanted. The nurse coordinator is a great resource for patients. I'm a little biased because that's what my career has been, but they are a liaison between you and the transplant team. So if the transplant team makes any decisions regarding your care, the nurse coordinator will relay that to you. And additionally, if you have any updates about your situation or your condition, the nurse coordinator will relay that to the team. So they're really there as a resource for you and to work together. The social worker, in terms of your transplant evaluation, will determine that you have adequate social support to be able to take care of the transplant and for somebody to help you. So patients that get a transplant are sick and they have a long recovery, and it's important that they have support from either their family or their friends to be able to come to all the appointments they need and make sure that they have, help with their medications and transportation. They'll also make sure that financial resources are adequate and that insurance-wise, you have enough insurance coverage to be able to sustain the transplant. A hepatologist is a gastroenterologist that has just specialized in liver and liver transplantation. So during the evaluation, they will just ensure that medically patients are appropriate for transplant, and if there's any further investigation required during their workup, so maybe this patient has been a smoker for years and we should get pulmonary function tests, they'll kind of highlight that to the team. The surgeon during the transplant evaluation ensures that the patient is appropriate for surgery and that they would be able to withstand the stress of surgery. And if they've had any other surgeries in the past, they're aware of that. So they know kind of what needs to be done. The pharmacist just looks at the medications the patient is currently on and make sure that nothing would interact after transplant. So they make sure that all their medication regimen currently is appropriate. And if anything would need to be changed prior to transplant or after transplant, we can address that. And the registered dietitian meets with the patient in case weight loss is recommended prior to transplant, or if weight gain is required. So patients with cirrhosis sometimes have problems with muscle wasting, so they can help with a kind of dietary plan that will help the patient and just optimize them before transplant. There's also evaluation testing that is required to ensure that a transplant would be beneficial and safe for a patient. So again, this varies from center to center, and this is not anything regulatory wise we have to do. So each center has its own preferences, what they like to do, but it involves some sort of cardiac testing. So based on your past medical history and your age, your center would determine what's an appropriate cardiac test for you to get. The typical, some kind of stress test is usually involved for patients over the age of 45 to 50. Under the age of 45, it might be an echocardiogram just to ensure that your heart's in good working condition. And if you've had any prior cardiac surgeries or cardiac events, as a cardiac catheterization would probably be necessary just based on what your center thinks. Imaging is important, and most centers require some sort of imaging. The preferred imaging for transplant evaluation is an MRI or a CT. And then there's also imaging required of the chest. So either a chest x-ray or a chest CT. And then there's a large set of blood work that is done at the time of transplant evaluation, just to kind of get make sure that everything is okay. And that's usually like a one-time thing. You get that large set of blood work. So during the transplant evaluation, a common phrase you would probably hear is the MELD score. And it's really called the MELD 3.0 score because they've changed it a few times and now we're at the 3.0 mark. But the MELD score is the model for end-stage liver disease. And it's a calculation based on lab values, gender, and weight used to determine the severity of liver disease. So the MELD score is used to determine where patients would fall on the transplant list, but it also gives us an idea of their 3-month mortality. The lab values that are involved in the MELD score is an INR, a creatinine, a sodium, an albumin, and a bilirubin. And transplant coordinators are not mathematicians, so they plug these numbers into a calculator, and you can find these calculators online yourself if you just type in MELD 3.0 calculator. And if you have access to your labs, you're able to check your score yourself. And it gives us a score. So the range is 6 to 40. 6 is the lowest score you could have. That would mean your lab values are nearly normal. And 40 is the highest you could have. So patients with a MELD score of 40 or close to it are typically in the hospital. They're very sick. Since your MELD score is based on your lab values, it will fluctuate each time you get it done. So sometimes I have patients call and they're confused and they'll say, my MELD score was a 15 last month and I got it done this month and it's a 17. And so we would expect some sort of fluctuation, 2 to 3 points either way. If it's high, we usually tell patients if it's higher than 7 or 8 points. So if your MELD score last month was 15 and this month it's 25, then we're going to start getting worried that your condition is kind of starting to decompensate. But it's a good tool for us to know how your body is compensating with its liver disease. And it tells us where you would fall on the list if we were to put you on the list. So there are a certain subset of patients where the MELD 3.0 score underserves them. So it doesn't necessarily reflect the severity of their liver disease. And they are eligible for additional, what we call MELD exception points. So they would get higher points on the list granted by the National Liver Review Board, which is a subset of UNOS, stating that their condition is appropriate for these extra points. Some of these conditions include hepatocellular carcinoma and cholangiocarcinoma, which are 2 types of cancers that affect the liver. And so because they have cancer in their liver and not because they have liver dysfunction, that's why they are able to get additional points on the list. And there is a certain criteria they need to fit into in order to get those additional points. And the transplant coordinators are really good at knowing that criteria and knowing if patients are appropriate for exception points or not. There's some additional testing that would be involved with each of these conditions more than if a patient was just listed with their native MELD score. So for hepatocellular carcinoma, which we call HCC, and cholangiocarcinoma, additional labs and imaging are required every 3 months in order to be eligible for those exception points. Hepatopulmonary syndrome and portopulmonary syndrome are two conditions where your liver disease has affected your lungs, and you're eligible for additional points. With those, sometimes additional blood work is required, and some additional tests like pulmonary function tests and chest imaging are required. The points work, it's kind of confusing how they work, but they are basically, they look at what the mean score of where a deceased donor might be. So if these patients are eligible for additional points, they're on our list, able to get the additional points. And then the hospital where the donor is located, the deceased donor, they look at the mean MELD score that they transplant at that hospital, and they subtract 3. So what we call is a median MELD score -3. These patients are eligible to get. So in Baltimore, our median MELD score is always 30. So patients around here get a 27 on the list, which is pretty high, and you're able to get organ offers. So once you're determined to be an appropriate transplant candidate from the testing and your meeting with the team, you're placed on the liver transplant waiting list. Frequent blood work is required to ensure that the MELD 3.0 score stays up to date on the waiting list. So if you are listed with a MELD score of 20, you would need to get your blood work done every month in order to maintain your spot on the list. And like I said, it fluctuates every month. So the frequency of blood work you may need to get may change, but it's based on how high your score is. That's not necessarily something you need to keep track of or know. Your transplant coordinator will tell you how high how high your score is and how frequently you need to get your blood work done. So this is a table that we use to let us know how frequently our patients need to get blood work done. And like I said, because your MELD score could fluctuate, it could be different from month to month. So if you had a MELD score of 14 and you only needed to get your blood work done every 3 months for a little while, and then your MELD score jumped up to a 20, now you need to get your blood work done every month. So it's important that you know how often you need to get your blood work done. But what's really important is that when you get your blood work done, you let your transplant coordinator know that you've had it done, because we're only able to use that blood work for a limited amount of time. And sometimes if we don't catch it right away, or we're not, there's always glitches with the lab work coming back to us. So if we don't know to look out for it, sometimes we miss it and we're not able to update you. If you miss your window of getting your MELD score updated, and you let your MELD score expire, you're not off the list. Your score just drops down to a 6. So you're moved to the bottom of the waiting list, which is not ideal. And especially if you have a higher MELD score, it's really important that you stay up to date with your labs. So for I talked about patients that are eligible for HCC exception points because the MELD score is not something that serves them very well. There's also living donor liver transplantation for patients whose MELD score might not be high enough to get a deceased donor, but they still need a transplant. So the liver has the ability to regenerate, making liver donation possible. So your liver is an organ that can regrow. A healthy liver can regrow or regenerate itself, which is why we can take a portion and give it to a deceased donor. Or I'm sorry, a recipient. A portion of the donor's liver is transplanted into the recipient. So usually around 60% of the donor's liver is given to the recipient. And this leaves the donor, we have to leave them with at least 30% of their liver, their native liver left. Within 6 weeks, the donor and recipient's liver has regenerated to the appropriate size. So it works that fast. Within 2 months, the donor had 30% of their liver left, and now they have an appropriate sized liver. Their liver will never look normal again, and I always remind them of that. So they will look like they've had a big lobe taken out of their liver, but it will be an appropriate size and be able to function fully within 8 weeks. And the criteria for living donors vary from center to center, but they do undergo an extensive evaluation. So living donor liver candidates, people that are interested in being living donors, undergo a workup that is similar to a recipient's. So they have imaging done, they have cardiac testing done, they have a lot of blood work done, and we make sure that they are as safe as possible going into the surgery. So if there is anything that makes the transplant team nervous, and this is pretty much straightforward across the board with any living donor surgery, but if there is anything that increases the risk any more than a normal abdominal surgery would, or the risks inherent to a normal abdominal surgery, most transplant centers will not move forward with that donor. And it's actually can be kind of hard to be a living liver donor. About 1 in 10 people at our center are able to do it for whatever reason. There are BMI cutoffs. There are some surgical procedures that people may have had in the past that makes them not eligible to be a living donor. So it's important that if living donation is something you want to pursue, that you have a lot of people come forward, because the person you think might be a great match might not be a great match. And for some people, we don't even know that they're, on paper, they look great. And then it may be a size issue. We need to have enough of their liver to be able to give the recipient, and sometimes it just doesn't work out that way. So transplant readiness, this is related to deceased donor. If you were to get a living donor, it's a planned procedure. So that's kind of different. And that's sort of the benefit of living donation, is that you don't have to worry about getting a call at any time of the night. But when you are listed for a deceased donor, that is something you need to be aware of. So if you have a really low MELD score, we kind of tell our patients, go live your life. If your MELD score is 8, don't worry about not going on vacation because you might miss an offer. They're probably not going to come to you because it's a scored system. We can kind of tell when you're going to get an offer. It's not necessarily a wait list. So you could be on the list for a little while, but if your MELD score never increases, you're not going to get a deceased donor offer. We usually tell patients what MELD score we transplant at. So like I said, we at University of Maryland and in the Baltimore region are usually around a MELD score of 30 for our patients to be able to get deceased donor offers based on their blood type. If you're one of the lesser common blood types, it's probably closer to like 20, mid 20s. So if you're an A, B, or a B, you would get a transplant faster. But if your blood type is an A or an O, usually you're looking at a MELD score of around 30 in order to get an offer, high 20s to 30. So when you start getting up towards the high 20s, we would tell you, be ready. You could get an offer, but it's always important to be ready just in case. Sometimes things happen and organs come to us quicker than we thought they might. So even if your MELD score is not as high as you think it would need to be to get a deceased donor, make sure you have plans in place. So you need a transportation plan to get to the hospital. You need someone to drive you to the hospital at any time of the day. And it doesn't have to be one person. A lot of our patients have different people that are able to drive them if they were to get a call during different times. So you might have somebody that can drive you on the weekends, and someone that can drive you overnight, and somebody that can drive you during the workday if other people are at work. So just make sure you have a solid transportation plan to get to the hospital. Make sure you have plans for dependent care that can kind of happen at the drop of a hat or a moment's notice. So have a plan in place for anyone that depends on you for care. So if you have elderly loved ones you take care of, make sure you have a backup plan. If you have pets or children, you need to find a plan for them to have care while you're in the hospital too. And then plan to stay in the hospital for 10 to 14 days, but it could be not as long or longer. And when you come home, you will still need help with those dependents. You're not going to be, ready to take care of people because you need to recover yourself. So when you're on the deceased donor list and your MELD score is high, you will get a call from an organ offer coordinator when an organ becomes available to you. It's really important that you prepare for this call. So make sure your phone number is able to receive calls from unrecognized numbers. That's a really common thing right now we have problems with, is that people get like robo blocker calls or features on their phone, which will block the numbers coming in. So disable that if you are on the transplant waiting list. And I'm sorry if that makes you vulnerable to robocalls, but I think that's a small price to pay in order to receive your organ offer. Make sure your voicemail box is functioning. So make sure that you have a voicemail box that is set up and that is not full. Because if you receive an offer and you miss the call, they will leave you a voicemail telling you to call them back within a certain amount of time. And a lot of people don't have functioning voicemail boxes. So that is really, really important while you're on the list. And then make sure your transplant team has a reliable emergency number or emergency contact person that they can contact if you are not available. So if you are not able to answer the phone because you're at a doctor's appointment, or maybe you just don't feel well enough to always catch all of your phone calls, make sure you give them a number or a couple numbers of reliable people that can get in touch with you if we are not able to. And the same rules apply to those people. So they have phone numbers that is able to receive calls from unrecognized numbers, and that their voicemail box is functioning. Now, when you get a call, this is how we work. Other centers are different, but our organ offer coordinators work remotely and are in different parts of the country. They don't necessarily reside in Maryland. So make sure that, it might be a number that's not a Maryland number calling you and that you still answer. So you need to be answering every unrecognized phone number if you're on the list. And then if they can't reach you, they will leave a message. And usually we give patients like 30 minutes, 45 minutes, depending on the nature of this offer, to call us back. If we don't hear back from you, we do move on to the next person. So that's why it's really crucial to answer your phone so you don't miss out on the opportunity to get a transplant. When they call you with the offer, they can really only tell you vague things about the deceased donor. The deceased donor is also a patient, so they are entitled to privacy and all the privacy laws that apply to patients. So they cannot tell you anything specific or identifying about this donor. They won't tell you the gender, but they will tell you about the age range. So usually we say, this person was between the ages of 30 and 40, and they can tell you if the deceased donor will be what's considered a brain dead donor or a deceased cardiac donor. And those are two different types of deceased donors you could get. And then they'll tell you when to arrive to the hospital. It may be that you arrive to the hospital and you might arrive in the evening and your surgery is the next morning, which is kind of the ideal case. We want to do it in a controlled setting where we have a few hours to prepare. We can get your blood work done prior. It's not always kind of how you see it in the movies where it's like, get here, rush, rush, rush. And you have like 30 minutes to get to the hospital. It's not always like that. It's more controlled usually. And we can say the donor is going to go in the morning. We want you to come tonight. You're going to come sleep at the hospital, and then you'll go up to the OR in the morning. So, and that's, like I said, the ideal way we like to do it. Once in a blue moon, it is the rushed scenario, but we try to avoid that if we can. When you come to the hospital, bring your ID and your insurance card with you, but leave valuables at home. You're going to be in the ICU for the first few days after surgery, so you won't need your computer or iPad. And when you're ready for that, when you come to the floor, just have a loved one bring it to you. And then, like I said, your OR time may be a few hours after your arrival. It's not always the rushed scenario that we see in TV. And sometimes your transplant team may decide that this organ isn't a good fit for you. So we do have patients that we call in for transplant, and then we decide for whatever reason this organ wasn't transplantable or it just didn't look good enough for you, and we will send the patient home. And that's okay. It doesn't mean that you fall to the bottom of the list, and it doesn't mean that you're never going to get transplanted. I think it's a good thing because it's a dry run for some patients. So you kind of get the feel of where you need to go, all the things you need to bring. So for the next time, you know that where you have to go and you're ready. And we don't want to transplant an organ into you and put you into this major surgery if we just don't feel confident that this organ is good. So it's, I think, disappointing when it doesn't turn out, but it's ultimately a good thing. So the transplant surgery itself will take about 4 to 6 hours. The entire liver is removed and then replaced with a whole liver from a deceased donor or a portion from a living donor. Living donor surgeries take a little bit longer than 4 to 6 hours. Deceased donors are a little bit faster than living donation. After surgery, most patients are in the intensive care unit for a few days. You may have a tube to help you breathe for a few days. And like I said, you'll be in the ICU. So you'll be pretty critically ill after surgery, which is to be expected. It's a large abdominal surgery. There will be pain after surgery, like any surgery, especially an abdominal surgery. So your transplant team will work with you to manage your pain to a tolerable level. It's really important that your pain is tolerable so that you can get up and move after surgery, which is the best thing that you can do to heal from surgery. You should be walking as soon as you can. So hopefully in the ICU, they would be getting you up and out of bed and walking. Your nurse and physical therapist will ensure that you can get out of bed and ambulate safely. But like I said, that's the most important thing you can do to heal from your surgery is to start walking as soon as it's safe too. When you're in the hospital and the transplant team determines that you're safe to go home, typically you'll be in the ICU, like I said, for about 2 days, and then you'll be downgraded to a transplant floor. And most transplant centers have floors designated to taking care of their transplant patients. So the nurses are really great at educating patients on their medications and understanding what happens during a transplant and supporting those patients. So most patients stay in the hospital for 5 to 14 days after transplant. Those are the two extremes. 5 is a very short time to stay after a liver transplant. And usually we don't see that. I would say the average is 7 to 10. And 14 days is kind of a long time to stay, but it just depends mainly on your condition prior to transplant. So some patients with liver disease are very sick prior to transplant. They themselves may require some hospital admissions prior to transplant. So if you're deconditioned prior to the surgery, you will have a longer recovery. And depending on the recommendations of the transplant team, some patients need to go to a physical rehabilitation center to make sure that they're safe when they go home with ambulating and performing their ADLs or activities of daily living. What's really important when you're in the hospital is to make sure you understand your medications and how to take them. And that's crucial for post-transplant success. So like I said, the nurses, transplant nurses, because I was one for many years, I feel like I might be biased, but they're really good at patient education and teaching you how to take your meds. You get your transplant meds a few times a day. So there's a lot of opportunity to understand your medications. Most centers also have some sort of medication chart that you can follow every time you get your medications. So it's important if your nurse brings your medication in that you and your family members are following along when she explains what medication is for what, so you understand what you're taking and you'll be ready to take on administering your own meds when you go home. And then another really important thing Before you leave the hospital, make sure you know how to contact your transplant team. It should be on your discharge paperwork and any educational materials that you get, but make sure you know how to call the transplant coordinator that will be assigned to you. It will be a different one, most likely, than your pre-transplant coordinator. So most centers operate with a pre-transplant coordinator and then a post-transplant coordinator. So make sure you know how to contact your new post-transplant coordinator, and make sure you know how to contact them after hours, on the weekends, and during holidays when the office might be closed. They'll always have a post-transplant coordinator on call. So just make sure you know the number to call. And then know why you should call your transplant coordinator. There are certain things that may seem kind of benign to patients when they go home, but if you're experiencing them, we want to know about it. So when you leave the hospital after transplant, you'll be on a lot of new medications, and it will be a big adjustment and a big learning curve for a lot of patients. So the first new medication that you'll be on is some sort of immunosuppression, and there will probably be a couple of agents that you're on. So the goal of immunosuppression is to decrease the body's immune response and prevent rejection of your organs. So these are vital to your transplant health. And transplant patients are on immunosuppression lifelong. So you will always require some sort of immunosuppression. As you go on from your transplant, it won't be as many agents and it won't be as much immunosuppression as you require, but you will always require some sort of immunosuppression because you have a foreign body in your body functioning as an organ. So the main one that we give patients, and it's pretty standard across the board, is called tacrolimus. Most patients are on that when they leave the hospital, and that's a lifelong medication. Another one you might be on when you leave the hospital is called Cellcept or mycophenolate. That's another immunosuppression drug. And then sometimes patients need to be on prednisone for the first few weeks after transplant. That's not always a long-term thing, and prednisone has its own side effects we try to avoid, but it helps in the very immediate period where we're trying to reduce your immune system very rapidly. So because we're trying to reduce your immune system really rapidly, we need to prevent opportunistic infections and protect patients against them. So patients are on an antiviral, an antifungal, and an antibacterial medication for at least the first 6 months after transplant, and they all kind of fall off gradually. The antifungal, you're only on for 1 month after transplant. The antibiotic, which helps prevent community-acquired pneumonia, you're on for 6 months after transplant. And then the antiviral, it depends on your case specifically, but what we're really trying to protect you against is a virus called cytomegalovirus, or CMV, which most people get in their childhood, but you can get it again if you're immunosuppressed, and it's a multi-systemic infection. So it's important that we protect you against that. And most patients after transplant are on antivirals for anywhere from like 6 to 9 months. And it's something we repeatedly check you for as you go out within your transplant journey is CMV. So for medication success, never stop taking a medication without talking to your transplant teams. Some of the medications do have some side effects that might be hard to tolerate, like I said, Prograf or tacrolimus, the medication that's an anti-rejection drug most patients are on, can cause tremors in some patients. If that's something that you feel like is not, you're not able to tolerate, talk to your transplant team, and there are other meds that we may be able to switch you around on. But never stop taking a medication because you don't like the side effects. That's why we have a whole team of people, including pharmacists, to get you on a regimen that works for you. And we gave you a transplant in order to improve your quality of life. So we want to make sure that we're going to do everything we can to make sure it's successful. Ensure that you carry a list of your medications that you are taking, and it is always up to date. So make sure that you carry it with you or you have it on your phone, so that if you were in an emergent situation where you went to a hospital that's not your transplant center and maybe not a transplant center at all, they would know what medications you're on, and would be able to get them for you. Also, on that note, if you end up in a hospital that is not your transplant center, you need to call your transplant center and let them know. They don't always call and tell us. So it's really important you let your transplant center know if you wind up in a hospital that is not where you are transplanted. Make sure that you're calling your team with at least 7 days notice if you need medication refills. So at University of Maryland, we give a couple refills on your vital medications, but not too many. We give you probably enough to get you through a few months, but we want to make sure you're getting your lab work done too. So make sure you're calling your team with at least a week's notice if you need more refills. And that's because some of your meds will require a prior authorization, which can take a few days to go through. So do not call us the day that you are out of medication and tell us you need medication. Obviously, we're going to do everything we can to get you your meds, but it's really important you give us enough time so that there is no lapse in you taking your medication. And then don't start new medications without talking to your transplant team. If you're worried about something, maybe your primary care doctor wants to start you on, call your transplant team and ask them if it's okay. That's why we're here. We're here to support you, and we're the experts on this. We don't expect you to be the expert or your primary care physician. So call us if you're worried about anything. And on that note, never take any kind of supplements or anything that might not be FDA regulated. We don't really know how those work with transplants and the transplant medications. So just avoid those at all costs. So your life after transplant. When you're initially discharged from the hospital, it's going to take a long time to fully recover from a transplant, especially if you were really sick prior to your transplant. So if you had a long illness and before you were transplanted, you're going to have to recover from that illness. And then you're also going to have to recover from about the biggest surgery that you could possibly get. So it takes patients a few months to fully recover. And some patients, if they were really sick before transplant, it could take them even a year. Like I said, the liver is involved in every body function and pretty much every organ system. So, you know, it takes a long time to get sick from liver disease, but it also takes a long time to recover from it. When you go home, there will be some activity restrictions from the hospital, and these might vary from hospital to hospital, but basically, while you have an incision that's not fully healed, you should not soak or submerge your wound. Showering is okay, but you shouldn't take a bath or swim until it's fully healed and you're cleared from your transplant team. You're not going to be able to drive for the first few months after transplant. So it's important that you have a reliable transportation plan in place to get appointments, to get to appointments with your team and to get your lab work done, which might be separate appointments. You're probably going to need to visit your transplant team at least once a week for the first couple months after transplant. We keep a really close eye on you. So you're going to need a transportation plan to get to those appointments. And like I said before, it could be a couple different people that are getting you where you need to go, but just plan on not being able to drive for at least 3 months after transplant. And that's probably the earliest estimate that you'd be able to drive again. Taking your meds is very important to a successful post-transplant journey, along with getting your lab work done. So when you go home from transplant, what we're really worried about and what we want to know if you have any symptoms of is rejection and infection. So infection is obviously concerning because you're immunosuppressed. And this is a big issue with liver transplant patients and all transplant recipients. So what can you do to prevent infection? You can practice good hand hygiene in your household. So make sure your household contacts wash their hands frequently, especially if they're preparing your food or assisting with your medications, and you need to wash your hands frequently as well. Make sure that sick contacts stay away. So not a lot of great things came from COVID, but I will say that people are more aware of how they are feeling and if they should visit vulnerable populations. I think people are much more aware of that now since 2020. So make sure that people know that you are now vulnerable to illnesses, and that if they are not feeling well, they should not come visit you. It is hard to avoid sick contacts that you live with, and that's something that you will encounter, obviously, especially if you have kids in your house. They bring everything in. So if your household contacts are sick, try to separate as much as you can. So be in separate rooms, use separate bathrooms if possible. And if you have to be near each other, you should wear a mask and they should wear a mask until their symptoms improve. And then it's really important to know the signs and symptoms of infection. So if you have a fever greater than 100 degrees, you need to call your transplant team. 100 degrees is actually a pretty low, mild fever for most of the population, and we wouldn't even consider it a fever if you're not immunosuppressed. But because you have a lower immune system, a fever is essentially an immune response. So it's not necessarily the infection itself, it's your body's response to the infection. So because you have a lower immune system, your body is not able to mount this great big fever response that we see, the kids have, where they might have a fever of 104 and be walking around fine. If you have a fever of 100 degrees, it means you have an infection most likely. If you have vomiting and diarrhea, and especially if you're not able to take your transplant medications, you need to call your transplant coordinator. If you have general malaise or weakness or flu-like symptoms, call your coordinator to make sure that you don't have anything going on. And if you still have your incision from your surgery, make sure that it looks okay and there are no changes. So if all of a sudden you notice new tenderness, warmth, increased drainage that's different from any drainage you had before, you need to call your coordinator. So rejection is the other thing we're really worried about with our liver transplant population, but recognizing rejection in liver transplant recipients can be difficult. There's not really any outward signs that somebody might be experiencing rejection. With a transplanted kidney, we can look at the urine output, and when it starts to decrease, that kind of clues us in that there might be something going on. We don't have that luxury with a liver transplant patient. So really the only way we know that something is going on is by trending your blood work. So that is why it is crucial to get blood work drawn as directed by your transplant team. It's probably going to be once a week for the first year almost of transplant, but it's really important that we establish baselines of what all your liver function tests look like. And when they start to increase, we can flag it and we notice that something is going on. Rejection can be treatable if it's caught early. And I think that for most transplant recipients, the term rejection is very scary, as it should be, but it doesn't mean an end all be all of your organ. It just means that your immune system snuck one by us and we need to outsmart it again. So sometimes it can mean that you just need to take steroids for a few days so that we can decrease your immune system. But it's important that we catch it early. And the way you catch it early is by getting lab work done. When you go home, there are some dietary concerns you should be aware of after transplant. Healthy, nutritious meals are really important for healing after transplant, and we recommend prioritizing protein. So because you had liver disease and your liver was not synthesizing protein or helping to make protein, you probably have a reduction of muscle mass. So after transplant, we want to increase that muscle mass. And the best way to do that is to increase your protein intake and to make sure you're getting good protein. Some medications may make it hard to tolerate large meals and can cause stomach issues. So if you're experiencing stomach issues after you take some of your meds, make sure you're talking to your transplant team. They can help adjust the medication regimen that you're on, but eating smaller, more frequent meals may be helpful. And that's what some people have to do after surgery to get enough calories in to heal. And then be aware that immunosuppressive medications make you more susceptible to foodborne illnesses. So you should avoid raw meat, raw fish, and raw dairy products. I feel like raw dairy is kind of having a moment right now, but it's really not safe for transplant patients or anybody that's immunosuppressed because of the risk of listeria. And also, I have read studies that the avian flu has been found in some raw milk. So it's really important that your dairy products are pasteurized and that you're eating fish is a great source of protein, but it needs to be cooked. And then make sure you're washing your produce. So, we talked about hand hygiene, but if you go into like a supermarket, like my kids are touching all the apples that are there, and I'm sure other kids are too. So make sure you're washing produce because everybody's been touching that fruit. But don't avoid it, just wash it. It's good and healthy and it's something you should be eating, but make sure you're washing it and being safe with it. And then you should speak with your transplant dietitian for tips on healthy post-transplant eating. They are part of the transplant team and they're a really helpful resource. There are some things that interact with the medications that you'll take too. So we tell patients to avoid grapefruit after transplant because it interacts with your medications. Another note about foodborne illnesses is that there every summer is some sort of recall on some sort of produce. I think last year it was watermelon got recalled. So just be aware that you are now the vulnerable population that they're talking about in the news when they talk about people that should not eat those products that have been recalled. So make sure you're just aware of anything that's been recalled and you don't ingest it. Special considerations after transplant. So transplant medications make you more susceptible to certain cancers, especially skin cancer. So you should wear SPF 50 every day and limit sun exposure if you can. If you're outside, wear long sleeves, wear SPF clothing and wear a hat. And then visit a dermatologist at least yearly or as often as they recommend. If you're of childbearing age, talk with your transplant team before getting pregnant. And this goes for men and women. Some of the transplant medications can cause dangerous birth defects. So if you are looking to be pregnant or your partner is looking to be pregnant and you are a transplant recipient, talk with your transplant team. And then vaccinations. Transplant patients can never receive live vaccines again. There aren't a lot of live vaccines that are out there. A few years ago, I think it was like 10 years ago, they offered a flu mist, which was a spray, like it was an intranasal spray. That was a live vaccine, but they haven't offered that in probably 10 years. But just be sure that if you are getting any vaccine, it's not a live vaccine. Another example of a live vaccine is measles, mumps, rubella, but that's usually given in childhood and adolescence. It's not really given in adulthood. And then make sure you're working with your transplant team and or your primary care physician to make sure you're up to date on flu, COVID, and pneumonia vaccines, which we recommend as a transplant center. Long-term transplant management, ensure that you're following up with your transplant team based on their recommendations. So as you go further out from your transplant, you will not have to see your team as frequently. So just make sure that you are following up however often they recommend, whether it's every 6 months now or 1 year. If anything changes in your situation, so if you move out of state, you have any major changes to insurance, or you change your address or your phone number, you need to let your transplant team know. If you move out of state, if you're lucky enough to be able to become a snowbird and move to Florida because you get tired of Maryland winters, let your team know. We can get you in touch with a transplant center in Florida and we can transfer care there, or we could see you once a year if you come back up this way. But just make sure that your team knows. And if you are moving to a new area, that you establish with a transplant center there. And then, like I said, you're more susceptible to certain cancers. So it's important that you maintain your cancer screenings, your skin cancer screenings, your mammogram and pap smears, colonoscopies, and prostate screenings, which your primary care and your transplant team can help coordinate these screenings. And then ensure that you're following up on your regular health maintenance. Make sure that you're visiting your dentist. Your dental care is really important to your overall health. And dental infections can actually be pretty severe. So it's important that you are making sure that your mouth is in good condition. Make sure that you follow with primary care. So your transplant team will do your transplant stuff, but you need someone else to manage the other health of you, like if you need blood pressure medication or anything like that. So it's important that you follow with your primary care physician, and then make sure that you, if you're a woman, you follow with a gynecologist and maintain good women's health. So that's my contact information. If you guys have any questions, I hope this was helpful to you. And please, if you have any questions, open it up to the Q&A or put it in the chat.
Thank you, Kate. Thanks for a great presentation. And I do have a few questions. Might start with Eloise. She has her hand raised. So let me see if I can allow you to talk, Eloise. If that's okay with you, Kate.
Yeah.
Okay.
Hi, this is Eloise.
Hi, Eloise.
I actually had two questions. At what age can a woman stop getting a pap test? I'm 15 years out and I'm 73 years old.
You should probably be around there, but that's based on the recommendation of your gynecologist or primary care physician.
Okay, and then I also had a question that I put in the chat thing. What do we know now about autoimmune hepatitis? That's what caused my liver failure, and I just can never get any real information on it.
You know, that is like a really complicated disease process. And there isn't a lot we know, and we don't know why some people develop it later and some people develop it younger. We have some patients that develop it in their 20s and they need a transplant kind of right away. And then we have some people that are later in life and we see it. But with all autoimmune things, we really don't know what triggers them. And they're all kind of related. So if you have one autoimmune process, chances are you're going to have another one too. But that is something that's still being heavily researched.
Thank you.
Thanks, Eloise. All right, Kate, we have another question here from Lisa. She said, I have no idea what to expect after my liver transplant, except that I will be going home on about 15 meds. But the JHH transplant Facebook page has brought up risk of skin cancer, problems with port healing, which has made me concerned about what else I don't know.
Yeah, so I recommend talking to your transplant team if you're concerned about things. I hope you found this helpful and gave you an idea of what to expect. It is really scary, right? Like you're going home in charge of this new organ, but that is why you have a transplant team, that they are your people that can help you. We do this 100 times a year, and you're going to do this once in your whole life. So that's why we're here for you, to help you and to support you. And if you're having any concerns about what to expect, talk to your transplant team. You know, like I said, you can expect to be pretty, it's going to take you a while to recover from a transplant. So give yourself some grace after your surgery, give yourself a couple months. You're not going to feel like yourself, and you might not feel like going out and doing the things that you enjoyed, but you'll get there eventually.
Okay, I think that's all we have, unless anybody else has anything.
I think I see a couple in the chat. If you want
Yes.
to address those. Let me see. Is the shingles vaccine a live vaccine? That one I can answer easily.
Yep.
Some of it is, yes. So you need to check before you get it and make sure that you're not getting the live version. And then, does the living donor have to have the same blood type as you? A living donor needs to have a compatible blood type. So what that means, if they are a blood type O, they can donate to anybody. If you are a blood type O, you need to have a blood type O. If you're a blood type A, you could have a donor that's an A or an O. If you're a blood type B, your donor has to be a B or an O. And if you're lucky enough to be AB, you can get anybody's liver. So it just, they do have to be blood type compatible, but maybe not the exact same blood type as you.
There was another question just now from Parmentier saying, my son who's attending college waiting on a liver transplant? What precautions should he take once he goes to college after
After
transplant?
transplant? Well, college boys are not known to be cleanly people. So, and I mean, I have a 10-year-old son and he's already heading that way. So I know, and I was in college. So make sure that he is in a place that he can keep it clean. We worry with any college student about meningitis. Make sure he's taking precautions against that. Everybody has to have the meningitis vaccine before they go to college. So it's important that he gets that. And then make sure he's eating well. Boys aren't also known to be the best eaters. Either they eat like everything in sight for 3 days and then they fast. So make sure he's eating good meals and getting good nutrition and good sleep. Sleep is really important to your immune health. So that's also important. And then another thing is, because it's the college culture, he absolutely cannot drink alcohol. And that needs to be counseled to him and really addressed. And I'm not sure his situation now, or if that's something he might do, but I think that just addressing that with him and having open, honest conversations with him would be really important, that he can absolutely cannot partake in any alcohol consumption after transplant.
Thanks, Kate. I'm gonna allow for one more question. Carl Jones raised his hand, so I'm gonna let Carl in and then we're gonna wrap up. Carl, you are able to talk if you unmute.
You hear me?
Yes.
I can hear you.
Okay. The question is, do they assign you a liver, or how that work?
Do they assign you a liver? Is that what you asked?
Yeah.
So how it works is that you are on a list, and the list is also sort of run with other centers that might be near you. So in Maryland, we're kind of combined on a list with Hopkins too, and GW and Georgetown. Those patients might be on a list, and they will have an organ offer. So they have a deceased donor that is appropriate for liver donation, and they run the list based on patients that this person would match with blood type wise. And then whoever has the highest score comes up first. Now, sometimes the team might not accept that for that patient, and then it kind of moves on to the next team. But that's sort of how the allocation system works.
Okay.
Thank you, Carl.
Thank you.
Thank you again to our great speaker for her insights. Our next session will begin at 10:30 a.m. Eastern Time. Please check the event website for the correct Zoom link. Please also visit Trio Maryland website, triomaryland.org, to learn more about us. We also encourage you to visit the Eventbrite site for more information on our sponsors who make this event possible each year. See you at the next session.